lecture on physics of MRI. And we now do that during the neurology clerkship. And so while it's fascinating, we're not going to explain how the images are obtained. We're more going to focus on the anatomy and some practical clinical points for now. But as a concise statement, maybe this is the best we can say it, that the images are obtained by exploiting the magnetic properties of protons in hydrogen atoms. And so it's really fascinating. I enjoy talking about it, but it takes at least 25 minutes to begin to understand how the images are obtained. So we're going to do that during the first week of the third year neurology clerkship. But one thing that is important, you know, when you look at CT, they all pretty much look the same if it's normal. I mean, skull is bright, hair is dark, CSF is dark, and so on. But when you look at an MRI scan, these are obtained in different types of sequences. And so they look very different depending on which sequence you're looking at. Okay, so we'll show you a T1 and a T2. There's also a proton-weighted image. We'll talk about flare and diffusion-weighted images and something called ABC. And they all have helpful things that they will tell you about what you're looking at in the brain. But it can be a little confusing because you'll see if you're looking at a T1, that looks a lot different than a T2. And just to recognize that by changing things up a little bit, we get different valuable information. So here's a T1 image. A T1 is really helpful just for normal anatomy. Okay, the gray matter looks gray, the white matter looks white. So the CSF here is dark. You get a nice sagittal look here of the cerebellum and the brainstem. We can see the superior and inferior colliculi, the thalamus and hypothalamus, corpus callosum. You know, it's just really nice for normal neuroanatomy. Turns out it's not nearly as sensitive for abnormalities as compared to a T2. Now notice when I go to a T2, everything will look completely different. CSF is now dark, and when we go to a T2 image, the CSF now appears white. Okay, and in a T2, the white matter, here we'll look at the corpus callosum, this now is dark. Okay, the gray matter out here is lighter. And so T2 kind of reverses things up, but for most things, for example, if we're looking for maybe some demyelination out here, like maybe the patient has multiple sclerosis, we're going to be much more likely to find that on a T2 image. So it's more sensitive for abnormalities. So here is a patient that has white matter disease, and that really stands out. You know, the white matter is normally dark, so this is more normal back here, and so we can see lots and lots of white matter pathology here very easily on a T2 image. Okay, flare images, otherwise known as fluid attenuation inverse recovery, are even better than T2, especially for if we're looking for white matter disease, like the patient has multiple sclerosis. And it's more helpful because notice that in a flare, the CSF is now dark. If we go back to the T2, the CSF was bright. So why is that helpful? Well, these lesions here in the white matter, which show up bright or white here, if our CSF is also bright, these can kind of merge in. It can be difficult to tell, is this normal or abnormal? So when we're looking for multiple sclerosis, obtaining flare images is very important, okay? Because you're going to more easily see the white matter changes. Now, if you have a patient that you think has multiple sclerosis and you order an MRI scan and you write, you know, consider multiple sclerosis, you don't need to tell the radiologist, don't forget to do flare and so on. There are protocols for this, and so these will be done automatically. Okay, the other two images we'll talk about are DWI and ADC, diffusion-weighted images and apparent diffusion coefficient images. And these are most helpful when we're dealing with acute ischemia of the brain. So when someone comes into the emergency room with an acute stroke, this is our most sensitive way of detecting the stroke. Usually a CT scan, an acute stroke, is often not very helpful. It doesn't show up for a long time on a CT. And likewise, the other images like T1 and T2 take some time to show up. But DWI and ADC are great for acute ischemia. And so here is a DWI image. And so ischemia shows up as something bright on DWI. Okay, and these now we can detect these sometimes within minutes of a stroke. We had a patient at the VA just a few weeks ago who just happened to be having an MRI scan for some other reason and had a stroke in the MRI scan. And you could actually see it in real time on DWI. So there it's bright. And the ADC is kind of your helpful confirmation. Now this one's real obvious, but sometimes we'll have a real tiny spot. And we're wondering, boy, is that real or not? So the ADC is kind of your second opinion. And in ADC, it's exactly the opposite. Acute ischemia looks dark on ADC images. Okay, so these are the main indications. And again, you don't need to remember this if you're in the emergency room and you think someone has an acute stroke and you send the patient down to radiology. These are done automatically. Okay, so we have CT and MRI scan, and frequently we'll give contrast with both CT and MRI. For CT, it's an iodine-containing contrast. For MRI, it's called gadolinium, and now there are some other options as well. Okay, both contrast agents have potential to damage the kidney. So that's called a contrast nephropathy. It's much, much more common with the contrast given with CT images. Okay, and so there are specific numbers about kidney function that will tell you is the patient safe to have it or not. All right, so, and I haven't given you those numbers, but just to recognize when we're doing our CT or an MRI scan, we do check the kidney function first and make sure that these are safe. Okay, why do we give CT? Well, why do we give contrast? If you give contrast to someone who just has a normal brain, looks the same. You look at the pre-contrast and the post-contrast images, very little differences. And so contrast is mainly helpful because it increases the sensitivity of your test. You're more likely to find abnormalities if there's anything that breaks down the blood-brain barrier. Anything destructive. So ischemia, a tumor, anything that has a destructive process to surrounding tissue is going to damage the blood-brain barrier. And so things essentially light up when you give contrast. All right, so here's a normal individual. This is a T1 image. Okay, so the CSF is dark, the white matter is white, the gray matter is gray. So this is before contrast, this is after contrast, and you can see a little bit of change, a little bit here in the venous sinus, a few little bright spots around the periphery of the brain, but not much change. This is normal. Very little change post-contrast in normal image. Okay, but here's a CT now, and so we're up near the top of the brain, and you can see there's a dark area right here. And this is what edema looks like on a CT scan. It's fluid, right? The CSF is dark on a CT, and so swelling in the brain like edema also has a dark appearance. But, you know, it's hard to know what that is. Okay, now we give contrast, and you see this spot light up right here. So this is a metastatic, I think, lung that had metastasized to the brain. And metastatic lesions often have a dramatic amount of edema around it. But giving the contrast allows us to see not just that there's a vague area of abnormality here, but now we can actually see the tumor. Okay, so contrast is really helpful, increases sensitivity of the test. So there are specific indications, and this is really important. You're working in the emergency room, or seeing a patient there, and it's, you know, your choice. Do you want a CT or do we want an MRI scan? CT images are very fast. Okay, we can just get the patient down to the radiology department, get the images, get the information right away. So That's an advantage. Takes longer to get an MRI scan. And so for head trauma in particular, someone's in a car accident, maybe they're confused or not waking up, that would be a time to get a CT scan. Is there a bleed? Do we have a skull fracture? We get that information quickly. The basic rule of thumb is if your top differential is a bleed in the brain, acute hemorrhage, always do a CT scan. CT is very sensitive for acute hemorrhage. And again, that's a neurologic emergency. This patient needs brain surgery. These are decisions that need to be made quickly. And so a CT, you can get that information. CT is also excellent for bone imaging. I didn't put some pictures in here of this, but we can do wonderful facial reconstruction from a CT in 3 dimensions. You can just sit it in your office, you can spin it around and you can tilt it different directions and look for fractures or anything like that. So if we're looking for a skull fracture or something, CT would be very useful. MRI is not very good at looking at bone. Okay, but there are distinct disadvantages to CT. It really does quite a poor job looking at the posterior fossa, meaning the brainstem or the cerebellum. All right, so for example, if you think your patient has lateral medullary syndrome, CT has no chance of detecting that. It's just too small of an area, and we'll see when we look at CT images through the posterior fossa, we get all these lines of artifact because of all of the bone around the posterior fossa. Okay, so it's not very sensitive for something in the brainstem or cerebellum, with the exception that if you think it's a bleed, like you think the patient has a bleed in the brainstem or the cerebellum, then you would still do a CT. But for most other things, CT is not going to be that helpful. Now, we are just starting to get sagittal images on CT, but they're not nearly as good as MRI scan, where we can do a whole sagittal section from right to left hemisphere of midline. So sagittal images, which are sometimes helpful, are much better MRI than CT. Okay, overall, CT is much, much less sensitive. Okay, so we're much more likely to find the abnormality on an MRI scan. So for neurologists, I would say when we get a scan, it's almost always an MRI scan. We'd rather get the better scan, with the exception of head trauma, acute hemorrhage, a few indications where CT are more helpful. So MRI advantage is kind of the opposite of CT. If you're looking for something in the posterior fossa, you need to do an MRI scan. Much, much more sensitive for just about anything you'd want to look for. And it's always a pity, when a patient has a CT scan and then we end up seeing them and, well, they really needed an MRI scan. So they get 2 studies, right? Better just to do one, just do the best study to start with. MRI does take longer, okay? And you need to have the patient lying very still during an MRI scan. So, if you've got an alcoholic patient in the emergency room who's kind of flailing around, you're not going to get very good images. That patient's not going to be able to lie still for the 30, 40 minutes it takes to get an MRI scan. So you need to have a patient who can cooperate and lie still for a period of time. And again, that patient, if they're moving around, if they're claustrophobic, you're going to get artifact and not going to get very good images. Yes?
Is there a difference in quality between the open MRIs and the closed MRIs?
Yeah, so that's a good question about open MRI scans. Not much. Is there much of a difference between closed MRIs and open MRIs? There is a little bit of difference. So our closed MRIs, we can get a bit more detail, but I would say it's not that significant. So yeah, if you do have someone who's claustrophobic, an open MRI is a really good option. Yeah, and oftentimes, if someone is claustrophobic, we'll give them a little sedation just to help them make it through the study. All right, so really important here that we can't do MRI scan in certain indications. The biggest one is pacemaker. Now, in a recent development, there are some MRI scans that are compatible with pacemakers, but these are not available in most facilities. So it's really important then, if you're ordering an MRI scan, you need to ask the patient several questions. The first one, do you have a pacemaker? Okay. And there are certain aneurysm clips or metal implants. So if the patient has shrapnel, We just saw a patient a few weeks ago, and MRI was really important. I mean, it was just critical, and he's had a piece of metal since, for 30, 40 years, right under the eye. And so the radiologist was saying, boy, if that moves, this could be devastating. So we should have plastic surgery come and take the little metal piece out, and then he could have the MRI scan. So we need to ask these questions before we send the patient down to the MRI scanner. And the radiology technicians will also ask the same questions again. So there's kind of a double screening here, but it's bad form to send someone down for an MRI who has a pacemaker. Remember, CT is great for looking at the bone reconstruction, putting it in 3 dimensions. MRI is not so good if we're looking for something in the skull. And claustrophobia, very common. I think more so where I work at the VA, you've got veterans who have PTSD and you put them into an enclosed space. And so claustrophobia is a big issue. We'll often give a little Valium or Ativan or something to relax the patient, but sometimes they just can't go through with it. And then an open MRI is a good option from there. Okay, something we won't talk about in detail in these lectures, but I just want you to have an idea that we can do a CT or an MRI scan and have the scanner focus just on the blood vessels. Okay, and we get a beautiful look at cerebral vasculature here. Here's a CT angiogram, okay, where we can see the internal carotid artery and the middle cerebral artery, the anterior cerebral artery. We look here at the posterior circulation, the basilar artery, and the vertebrals. Okay, so that's helpful, again, especially in stroke, to look at the cerebral vasculature. And here's an MR angiogram, okay, which likewise, just everything we've been talking about. Here's internal carotid, MCA, ACA, basilar artery, and the posterior cerebral arteries coming back here. So we can look for an acute stenosis or any focal problem of the vasculature. We can do this down into the neck, so we can look at the carotid arteries as well. And if we want to look at the veins, we can do an MR venogram. Okay, and so here is the superior sagittal sinus. And so much nicer now that, a conventional angiogram where you're having to put dye in has some risk, really. So to be able to do these tests non-invasively is fantastic. Okay, so I want to go through on a T2 sequence and just show you some normal anatomy. And I was thinking about it here last week and decided, we're coming up to the very end here of your first year of medical school. And so I think for the next little bit, just relax. We're not going to ask any questions on identifying structures. So this will be just kind of, I didn't want to dump all of this on you here right at the end. So we're just going to go over a little bit normal. Okay. Now I will say, I did spend the time labeling all of these nicely. So. Now there's a lot we can identify up here, but this is neuroscience, right? So, the nasal septum and the maxillary